Okay, thank you very much for your presentations. Next, I would like to invite Dr. Huỳnh Nghị Nam from Da Nang Hospital to present about left main occlusion in the acute setting, what really matters.
Good morning, dear esteemed chairman, panelists, and colleagues. My name is Huỳnh Hữu Nam. I'm working in Da Nang Hospital. Today, I'm very happy to present this conference about the topic left main occlusion in acute setting. What really matters? As you know, left main occlusion is different battle. It's not like other coronary artery occlusion. Left main supply the most blood for the left ventricle. If the patient have a right dominant coronary artery distribution, so left main supply about 55% blood for 75% blood for the left ventricle. If the patient have a left dominant coronary artery distribution, so maybe the whole blood supply for left ventricle from the left main. So it's very important. Yeah, and luckily, so the rate for primary PCI in the left main is low, just 0.5%. And when left main occluded, everything can happen very fast. Blood pressure collapse rapidly because the cardiac output fall to nearly zero and tissue oxygenation drop rapidly. Malignant arrhythmias can occur and repeat it. And metabolic acidosis worsen, and the patient get reduced perfusions in brain and kidney. Yeah, and everything can happen. That's the reason why. That's the reason why. That's the reason why the rate of out of hospital sudden death very high. The patient can die before he come hospital, and the patient can easily get the VT or VF when he admit hospital. And also, the patient also have a high rate of profound cardiogenic shock. So when we face with this situation, no machine for error. We have to do everything precisely, and the patient can deteriorate faster than our workflow can adapt. We just remember that. And every second is a negotiation with the biology. You just keep in mind, not just anatomy. If you just focus on anatomy, so forgot biology, maybe you can leave the patient. And the most important thing is restoring oxygen delivery and circulatory instability as fast as possible. Yeah, it's very important, I think so. I would like to present with you the case I did 5 months ago. The patient is male, 61 years old. The past medical history is CBD and admitted my hospital 5 months ago. Chief complaint is chest pain for 4 hours. In ER, at the gate of AR, the patient very severe acidic, slow to respond, severe chest tightness, dyspnea, and heart rate is fast, blood pressure low, saturation is low, and lungs is extensive lateral crackle and cold extremely. Is very severe at the gate of ER. So after about 1 minute, the patient suddenly lost consciousness with no powerful pulse and monitor show VF. So we do PCI and defibrillation very quickly. And luckily, after that, the patient subsequently recover sinus rhythm. But very severe. The blood pressure is low, saturation is low, heart rate is fast, and bilateral crackling in lungs. And here is the ECG show that the sinus rhythm, but and you look in the AVR ST elevation a little bit, and bedside echo, we see global hypokinesis and left ventricle, ejection fraction very low, and TAPS is still okay. Patient didn't have a history of cardiac disease, and now it's present like ICS, so we diagnose the very high risk non-ST elevation MI and severe cardiogenic shock. So look back to the literature. So the size of AVR ST elevation in EKG can check the left main occlusion with a high sensitivity and high specificity through a lot of studies. So keep in mind when you see the patient with severe and look at the ECG, ST elevation in AVR elevation. So we need to think about the left main occlusion. And this patient we treat with norepinephrine and dobutamine, very high dose, and we loaded dose of anticoagulation, antiplatelets, and statin, oxygen therapy very much. And after 5 minutes, the patient will stable, going better, and blood pressure is 90 over 60, saturation is still okay. And we consult cardiac ICU physician, cardiac surgeon, and interventionist. And after 10 minutes later, we transfer the patient to cath lab. And we also prepare the best ECMO and AIBP. That's all the circulation support we have in my hospital, just ECMO and AIBP. And here is angiogram. Look, in left man, almost occluded. Maybe it's the topus in the left man from the oxstem. And from the caudal view, we can see the maybe intact oxstem observed. So we think this is very important to make a decision what we should do in this situation. The patient at that time very severe consonant, cold extremely, very fast heart rate, blood pressure still okay, but very high dose of vasopressor. And what should we do? A lot of surgery, we should think about that. We should put AIPP or ECMO first. After that, we revascularization, or we revascularize, and after that, we put AIPP, or just we do no. We say no. This is very severe patient. We just medical treatment only, because after that, after we stabilization patient, and we do revascularization later. Or if we choose revascularization, which one? Angioplasty or CBG is better? So that's a big question, and we need to answer quickly because no time for patient. Patient can die every moment. So look back to the to answer this question. Look back to the FIT STEMI. The FIT STEMI trial can confirm that we should do primary PCI as soon as possible if the patient STEMI and cardiogenic shock combined. So it's proved that if we delay, the more patient can die. It's proved in the FIT STEMI, as you know. And in the ESC 2022, also suggests that we use CBG with the class 1A, PCI class 2A for the patient with low risk left main stenosis and suitable for PCI and CBG. But remember, this is just the guideline for a stable patient. It's not a shock patient. The patient was unstable. So for unstable, how about that? We look back to the shock trial. Shock trial is the trial include about 300 patients. They randomize emergency revascularization and initial medical stabilization first. So this trial results show us that we should do immediately revascularization strategy can improve the secondary endpoint in 6 months and 1 year. And look deeply into the results of trial. If we choose CBG, so we can take longer than PCI. CBG in average time is 2.7 hours, but PCI less than 1 hour. So if you want to do quick, maybe we choose PCI is better than CBG. And look deeply in the subgroup. If the patient is younger than 75, so if we revascularize the patient it's better than medical treatment. If the patient is older than 75, maybe we aggressive to do the procedure. Maybe it's not good for the patient. So for conclude the shock trial, early revascularization should be strongly considered, especially the patient younger than 75 years old. And Asian Pacific Society of Cardiologists consensus 1 year ago also recommend us to use urgent revascularization for the patient with left main stenosis and unstable. And ACC AHA also recommend us to use private PCI for to treat to revascularization in acute setting. How about mechanical circulatory device? A lot of trial have been done, but the result is no, it's not okay. So I recommend us not routine to do AIBP or add more for the patient with AMI and cryogenic shock. So in my opinion, therefore, this intervention shouldn't be used only when truly needed. So our strategy is revascularization first and to PCI. And the circumflex ostium is still intact, so we choose the strategy just crossover stenting. And here we choose radio assess 7 French EBU 3.5 and 2Y. The first Y we go to diagonal, not the main vessel. After that, we did thrombectomy and dorsal balloon just 45 minutes. And here is the picture. We just put the stent crossover from left main to LOD. And the duration of angioplasty only about a few minutes, 3 to 5 minutes, and very fast. After that, we haven't done the port dilate. We wait about 10 minutes. And what did we do in 10 minutes? We put AIBP for patient. I think we can support the circulation more in the waiting time. We didn't do port because we wait the time for the blood supply for the myocardium. And after that, we did part with NC balloon 4-year-old at 11, and here is the final result. Very, very good. A little thrombus in the circumflex ostium, but the flow is okay. Here is the procedure is getting well, very fast, but the patient is not really like that. The patient, after that, we transfer the patient to ICU and a long day at ICU. After 18 hours, the patient have a severe cryogenic shock, require 3 high-dose vasopressor. So we need to put high lactates, and we put a VA ECMO. At that time, we don't have more method to support a patient. After 5 days, we quit VA ECMO, and 10 days later, we activate patient. Okay, and after about 10 days, then the patient would transfer to my house and my department, internal medicine, interventional cardiology department, and we optimize the heart failure therapy quickly. We start and optimize that. And here is 1 month, 2 months, and 3 months later, and right now, he have no chest pain. New York Heart Association, just class 1, full recovery, ejection fraction is 52. And here's a prescription for him right now. And look this picture. I'm so happy to look this picture. Maybe you look and very happy, and also with me. Here the echo 2 days ago, and the motion is very good, and the pictures video is permitted patient, and he can bring the bunch of banana very comfortably, maybe stronger than me right now. Okay, so I'm so happy to see this video. I would like to share with you in this conference. So for conclusion, essential core for left main occlusion is early detection. Look in the EKG and in clinical presentation of a patient, and timely activation and mobilization of available sources, and private PCIs prioritized when hemodynamic stability allows. And mechanical circulatory support used only when truly necessary. Prefer simple technique. PCI is fast, it saves time, and early initiation and optimization of heart failure therapy. Close outpatient follow-up. Thank you very much.
Okay, I just want to make a comment. I think we don't have many times for questions, but thank you for your talk. It was great to see that what you do in the lab affects, people's lives and families. So it was great to see that the patient did very well. So at the end, if we have some questions, we'll come back and ask you some questions. Okay, thank you.